Hi, everyone. It's me again, Rami Tadros, here to present on BTK interventions. I'm going to talk about access, how to do it, and the principles of treatment. So some considerations for pedal access is, number one, I only consider pedal access for critical limb ischemia. It's not something I generally do or consider doing for claudication. I think this is very important. Know your indications. Two is when to consider femoral and pedal access versus pedal only. I tend to lean towards doing femoral and pedal almost always. And the reason for this is this allows me to treat the pedal access vessel after access. It's quite common to have a pedal access dissection, spasm, potential other issues once you've percutaneously accessed the pedal vessel. Also, this helps me with hemostasis. How to access? I think for the anterior tibial, the dorsalis pedis, and the posterior tibial, it is very easy to access using duplex ultrasound. These vessels are very superficial and readily visible. When it comes to the perineal, I often will use fluoroscopic guidance, sometimes coupled with angiography. I tend to find that it's easier to access from the anterior leg. And again, usually this is in the setting of a calcified vessel, and it's usually easy to identify, but you can use angiography as an adjunct. Some key steps. Number one, prep both groins and the target leg in advance. I like to plan these procedures. I don't like to prep the leg once we've started the procedure, although that occasionally can be necessary. Know your anatomy, know what your target vessel is going to be. And I've prepped both groins. The access can be ipsilateral or contralateral. So typically you're going to get, I typically will get contralateral femoral access, and then I will directly access our target leg, and I will know my target tibial in advance. I have done radial pedal, which is more challenging, but it can be a technique that can be useful, especially for more proximal disease. You need to access the target vessel. Again, I start small. I typically will use the inner dilator of a 4 French micropuncture sheath, and then I will increase the size as needed. Certainly, if I have trouble crossing, I may need to put in a 4 or 5 slender sheath from Terumo. But most of the time, I can actually accomplish this simply by using the inner dilator of a micropuncture set. And then I typically will wire from above and below. I try to remain luminal, but not always possible. I will go subintimal when necessary. And then one technique that can be useful in this scenario is a double balloon technique. You can inflate 2 or 3 millimeter balloons from above and from below to allow reentry. Alternative techniques include standard glide wire and glide catheter combinations, or any other type of 014 wire with catheter combination. Once a wire is snared through and through, you can essentially pick your poison as to how you want to treat the lesion. You can go with angioplasty, whether it's drug-coated balloon or not, lithotripsy, atherectomy systems, again, your choice of atherectomy system, and then your choice of stent. Typically for the SFA and popliteal segment, I'll use drug-coated stents like the Illuvia or Zilver. When it goes below the knee and I have to stent, I typically will use Zions or some other drug-eluting coronary stent. I think this is really important. Once you've treated your target lesion, then your steps on removing access and ensuring that your outflow vessel remains intact is really important. What I typically do is I will remove the through and through wire, and I will position a fresh wire above the level of access or proximal to the level of tibial access. I will then take an appropriately sized tibial balloon and position it proximal to the access site. Once I'm in position, I will remove my tibial access, and I will apply manual pressure. After removing the sheath, I will then cross the access site with a wire and balloon. I will then inflate the balloon for about 5 minutes and then deflate the balloon, assess for hemostasis and patency of the distal vessel. So to highlight these things with a few cases, my first case is a 67-year-old diabetic with CLI who had a prior common femoral endarterectomy and what we thought was just an anterior tibial artery occlusion, but then later learned that it was much more complex than that. So you can see this is the original angiogram. The proximal SFA is patent without obstruction. You can see this as we're marching down. The patient had a knee replacement, which certainly makes imaging difficult, and so you need to get the appropriate gantry angle to see. But once we're behind the knee, you can see the popliteal artery is totally occluded with an anterior tibial artery coming back. So in this case, we use ultrasound-guided access to access the anterior tibial artery above the ankle and send a wire from above and below, which I will highlight here. So again, we're unable to cross from above. Once we have access from below, we are able to snare a wire through and through. So you can see here, this is the 014 wire snared, and the 014 wire is being pulled through our 6 French access, which in this situation is from the contralateral groin. The snared wire gets pulled through and through. Now you'll, here in a moment, have through and through access. Once you have through and through access, treatment is typically pretty easy. You can drive a train through this vessel without much difficulty once you create that rail. And so in this situation, we pre-dilated with a reasonable result. However, I chose to stent this, given that it was a total occlusion. My preference in total occlusions is to stent. In the tibial portion, we're using a Zions coronary drug-eluting stent. This is a 38 millimeter stent. And then we follow that with drug-coated stents all the way up. And then, of course, post-dilate those stents. You can see this is the end result with perfect flow into the anterior tibial artery. This person went on to heal their toe wound without any issues. Our second case is a 65-year-old diabetic with a non-healing TMA site. Patient had a prior SFA stent and a known PT artery occlusion. You can see we have a 6 French sheath up and over from the contralateral groin. Imaging the leg, the SFA and popliteal segment, not terrible. The proximal anterior tibial artery here is occluded. You can see a large anterior collateral. You can see the tibial-perineal trunk and the perineal artery, but an occluded posterior tibial. So again, using ultrasound guidance, we access the posterior tibial artery. Again, sending the 014 wire up. Ultimately, we were able to snare that wire. Now, once we have our through and through wire, we can then start treatment. In this case, we performed an atherectomy and angioplasty. And you can see excellent flow now into both the posterior tibial and the perineal arteries. Thank you very much. Enjoy the rest of your day.